Welcome, everybody. I am Pierre. I am the Executive Director of the Kerry Healey Center for Global Healthcare Entrepreneurship at Babson College and the Chief Medical Officer of Harbor Health Services, a network of 7 community health centers across the state of Massachusetts. I'm thrilled to be here. Today's session is the first event in the Health Equity Series hosted by MassChallenge Health Tech and by the Mass Health Policy Commission. As many of you know, MassChallenge Health Tech accelerates healthcare innovation by matching top digital health startups with industry-leading strategic partners to achieve actionable results. Health equity has emerged as the overarching challenge area for the health tech program this year. So with the Mass Health Policy Commission, which is an independent state agency charged with monitoring the growth of healthcare costs and improving quality and access for all people in the Commonwealth, MassChallenge Health Tech are excited to really launch today this health equity event series focused on helping innovators gain insight into how digital health solutions can help advance equity by meeting the needs of diverse populations. So to kick off today, we're going to start with a fireside chat that's going to focus on what innovators can learn from community health centers. You know, in the 1960s, community organizers and physicians partnered to design these new clinics that would be different because they would serve as anchors for the community by providing health services, of course, but also by addressing social determinants of health. Today, there are 1,200 community health centers in the US, with over 10,000 locations serving 28 million people. So our panelists today will help us explore the role of community health centers, often referred to as federally qualified health centers, in advancing equity, and they will answer your questions as innovators who are trying to figure out what solutions could help all in this new space of healthcare innovation. There'll be designated Q&A time at the end, but please, as you're having questions throughout the discussion, use the Q&A feature of this Zoom so that we can keep track of the questions and find the themes that are of interest to you. So I'm honored to be with 3 people with careers that have had an incredible impact on the lives of many. I'll introduce them by just name and title, and I'll allow them to say a little bit more about themselves and about their organizations as they answer their first question. So our panelists today are Michael Kerry, who is the President and CEO of the Mass League of Community Health Centers. We also have with us Dr. Michael Tang, who is the Chief Behavioral Health Officer of Dimock Center. And then lastly, we have Emily Johnson, who is the Director of Community Outreach at the Lynn Community Health Center. I'll say that they all 3 gave me permission to refer to them by their first name, but because we have 2 Michaels, you may notice that I will call Michael Kerry Michael and Dr. Kent Mike. So with that, I'll start with Michael Kerry. Michael, community health centers have been around for a long time, but it actually all started here in Massachusetts. Can I ask you to share a little bit, for those who are not familiar with community health centers, what our work is, what our approach is, and maybe a little bit about our history?
Yeah, so thank you, Dr. Pierre, and to the other panelists. It's a pleasure to be on with my health center colleagues. I'd probably start by saying that people don't know that the context for the birth of community health centers. One of the things that's important to know is in the 1960s, we were dealing with the civil rights movement. If you know that in 1963, after the assassination of President Kennedy, Lyndon Johnson went forward with the urging of advocates and passed the Civil Rights Bill of 1963, the Voting Rights Act of 1965, but the backdrop to that was a segregated society. And it wasn't just about desegregating lunch counters and schoolrooms. It was about an unequal and unfair medical system as well. Many of our hospitals across the country were segregated through the 60s. Medicare and Medicaid were civil rights bills that forced the integration of our hospitals across the country. You might not know that folks as brilliant as Dr. Pierre, who were around and physicians at that time, had difficulty getting into medical associations or getting residency programs or getting into our major hospitals. So that's the backdrop. And then you had a collection of activists like Jack Geiger, God bless his soul, who just passed away just a month ago, with Count Gibson, who were at Tufts here in Massachusetts and Boston. Then you had folks like Dr. Hatch and Dr. Smith in Mississippi, Black clinicians, who knew that this was their moment. They were followers of Dr. King, and they wanted to launch a movement around community health. And they launched the community health movement in 1965 with the help of Senator Kennedy. And Dr. Pierre, just to round that out, it was never about just getting people medical care. Jack Geiger understood that it was about the irrigation systems and the water supply in those neighborhoods. It was about empowering community members to serve on the boards of those health centers, which now our health centers have over half of their membership, their board are community consumer board members. So it was about empowering them. Ayanna Pressley, Congresswoman Pressley, has a phrase. She says, those closest to the pain need to be closest to the power. She said that during her campaign. Jack Geiger and the folks who launched the health center movement in 1965 knew that and built that into the model of community health centers. So we are all across the country, as Dr. Pierre said, just giving you a snapshot of Boston, just some numbers that I think speak to where we are. 460,000, over 460,000 patients just served in Boston. That's 1 in 2 Boston residents. We have 70% of our patients are low income. Over 81,000 of our patients are children and adolescents. 78% of the patients identify as ethnic or racial minority. Over 80% of our patients collected statewide and even in Boston are publicly subsidized. That means whether you have a job today and you're privately insured, you're at a health center. Whether you lose your job and you're in between and you're on Medicaid, you have a health center. Whether you have Medicare, you're at a health center. No matter where you are in that sort of insurance life cycle, you are probably, if you are in the city of Boston and across the state, you may be getting your care at a community health center. That is our history. And that is our mission, is to serve people no matter where they come from, no matter what they look like, and no matter what insurance they have.
Thank you so much, Michael. It is an incredible history. And I think this whole theme of health equity is, resonates with what we're seeing now with the pandemic. It also resonates with something we've been struggling with forever. I think for those of us who are part of the community health centers, we understand that this is our day-to-day lives. And so with that, I'm really gonna ask Mike and Emily to give us a sense of what it's like. So I'm gonna ask Mike first to share a little bit about your work and what you see and what are the issues that your patients typically face, especially when it comes to behavioral health, a part of what we know is really important, yet still stigmatized and addressed and accessible in very different ways, depending on your socioeconomic status and or your ethnic background.
Yes, thank you so much, Dr. Pierre. So as a pediatrician, a primary care pediatrician, and a child psychiatrist and adult psychiatrist, every day at the Dimock Center, we see the tremendous needs of our patients, both the medical needs, the physical needs, the behavioral health and substance use disorder needs, and the social determinants of health. Community health centers, as Michael Curry said, are a huge part of the solution. At the Dimock Center, we are a multi-service agency. We are a federally qualified health center. We're also a community mental health agency. And we're also an early childhood agency with an early Head Start and a Head Start program, serving nearly 20,000 people a year here in Roxbury. And we're the largest employer in Roxbury with over 500 employees, most of whom are from this community. And so we are uniquely qualified to provide this comprehensive biopsychosocial approach to health. That's a model that's fully committed to patient care. I mean, that's really our only mission, is providing the best care for our patients and our community. And to do that requires a really comprehensive team, right? We know better than anyone, it's not about the doctor, right? It's not about the doctor who does everything. The doctor has a piece of this, but so does the nurse, so does the medical assistant, so does the social worker, so does the psychiatrist, so does the community health worker, as Emily is going to talk about. And so what we're really trying to do is meet those needs of our patients, and they're substantial. And as you talked about, Dr. Pierre, the behavioral health needs in our community are so important. We know This community, which here at Dimock is over 75% on Medicaid and uninsured, so definitely underserved, is over 90% identifying as African American or Latino, so facing every day the systemic racism and barriers that we see in our society. And it places a tremendous burden on depression, anxiety, trauma, and substance use. And again, community health centers are uniquely qualified to meet this need because we're trusted providers. Literally, as a pediatrician, there are families that I see that have been with us for 3 generations, right? You know, the grandmother and the father and the child all attend, you know, the same Dimock pediatric clinic and have these trusting relationships. And at Dimock, we're then able to leverage that into access to behavioral health care to overcome that stigma that you referred to, Dr. Pierre, where we can say, hey, you know, wow, you're going through a lot of stress right now. You know, we don't even have to put labels on it. We can just say, why don't you talk to my colleague over here, who is a social worker, but talk to my colleague, talk about everything that you're going through. Let's get you into care right away. Let's get you into someone to talk to. Just take that burden off your chest a little bit. And really provide that care. And here at Dimock, we have no wait lists to reach therapists, no wait lists to reach psychiatrists, which is a tremendous innovation, and technology is a big piece of that. So really, health centers are not only innovators in providing care to our communities, we believe we're uniquely qualified to be innovators really for healthcare and care throughout the country.
Agreed. I mean, I think even by design, right? Michael shared our history and you're sharing your model, which is beyond just the healthcare. You spoke about how, of course, all of our physical needs are met there, and from the health perspective, most health centers have more than one service. So people don't realize that. We have primary care services, but we also have behavioral health services. We often have dental services. We often have, you know, eye services, and we continue to add everything as much as possible to be a hub, really a health hub, a community space where people find all of their healthcare needs met, but also because, as we mentioned, a big part of how we were designed was to address the social determinants of health. We will add additional community services. We will add outreach programs. We will go to the patients if we need to go to their homes or their spaces to learn more about them. And so with that, I'm going to ask Emily to share a little bit about that side of our services. You know, one of the things that we're known for is having these long-standing relationships with the communities that we serve. And many of these communities have had really negative experiences with the health system. Just our own history as a health system is the history of America. And so our patients have experienced the same things that we experience at the bank or trying to buy a house and so on and so forth. So there's a lot of distrust. Can you tell us a little bit about how you overcome that and how you continue to help keep our communities connected to us as health centers?
Absolutely. Thank you, Dr. Pierre. My name is Emily Johnson. I'm the Director of Community Outreach from Lynn Community Health Center. And I think one of the most important things, and Dr. Tang spoke to this briefly, is employing the community at the community health center. That's the most important. That shows trust. That gives back to the community. That builds on the community. That empowers the community. It brings a voice to the community to be a part of a federally qualified health center, of an agency that is there to support the community. Where my team comes into play is I supervise a group of community health workers and care coordinators that will literally be feet on the street. They will go out into the community, meet the patient in their home, provide the health education, accompany them to the appointments. And then in addition to that, to address the social determinants of health, to assess what is your living condition? Why does your child keep going to the emergency room for asthma? Oh, it's because there's mold in the apartment. What can we do to address that? How can we improve the quality of life, which will then improve the whole health and wellness for that individual? So we may support the patient with applying for affordable housing, making sure that they receive all of the entitlement benefits that they're eligible for, such as SNAP or WIC. At Lynn Community Health Center, we have our own WIC department. So if I, encounter a pregnant woman that doesn't have proper nutrition, I'm able to literally walk her to the next office and say, here, meet with my colleagues and let's get you some support with that. We have, strong partnerships with our sister agencies, with our local economic opportunity agencies, local justice centers that we can refer our patients to. And again, with the work of community health workers, literally take the patient there and work with them and not do for them, but teach them how to do to therefore further empower them for their independence and their personal growth and development.
Thank you so much, Emily. That really, I love your emphasis on including people and not designing for, but designing with, or sometimes even letting others lead. And that's a big part of who we are as community health centers. That's a big theme of what we embrace, and how even in designing new solutions, even the vaccine, you know, where should we give it? We would ask, you know, what's most accessible to you? What are you worried about? How can you help us? And I think that actually in some ways, you know, for a lot of the members on the audience here, they're entrepreneurs, startups, you know, and innovators on the call. And many entrepreneurs embrace this concept of human-centered design, right? This idea that you include people and that you really try to design things around them. But we find that quite a few of those very humans that we're trying to design for, especially people of color, people who have a disability, people who have a socioeconomic barriers, they tend not to be, they don't have a seat at the table when these solutions are being designed, right? And so we have wonderful, right here in Massachusetts, wonderful tech partners, wonderful investors, great resources. Yet when we're designing these solutions, the entire group that truly represents the state is not at the table. So I'm going to ask Michael Curry to give us a little bit of advice about how startups can do a better job at capturing these voices.
Yeah, Dr. Pierre, you remind me, as you teed that question up, you remind me of my predecessor, Jim Hunt, former president, CEO of the Mass League Community Health Centers, had a phrase that I think applies to so many aspects of our lives. And he said, if you're not at the table, you're on the table or you're on the menu. So I want that to sit with those entrepreneurs out there for a minute. If you're not at the table, you're on the table or you're on the menu. And what that applies, how that applies here is, you know, a very consumer-centric approach and requires, and quite frankly, the best product is when you invite people to the table to build a design. And I think what we're finding in many other areas of society, especially with the racial reckoning that's going on right now, is that people of color, poor, people across the spectrum have not been invited to be part of these conversations. And then people design products and services that don't fit our needs. So, you know, right now, just as an example of an emerging technology that people are all over right now is telehealth. Now, if you go back 2, 3, 4 years from now, there were many beating the door, including the Mass League Community Health Centers, our member health centers, hospitals, saying we have to adopt this technology. We need the regulatory framework. We need people in the space of developing the design of what this technology would be and getting us ready for it. And we were not ready to do it as a society. We were not ready to teach our kids remotely. We weren't ready to provide healthcare remotely. And quite frankly, we weren't even ready to work remotely. And then all of a sudden the pandemic hit and it quantum leaped us forward. And now we're starting to meet patients where they are in their homes, at their workplace, wherever they are, that we can reach them. And what we're seeing is some challenges, some digital divides, some broadband issues, but we're also seeing some unique opportunities, Dr. Tang, as we're now seeing we can reach more patients around behavioral health care that is giving us increased access. So I give you that example to all you innovators who are out there, that you have to anticipate what's next. You have to be thinking about whether it's a pandemic or some other natural disaster, whether it's just the evolution in the healthcare system with value-based care. Look it up if you don't really know what the concept is. And you need to be ahead of where the industry is and designing what will help Dr. Tang and Emily do their jobs and Dr. Pierre do their jobs more efficiently, more timely, more cost-effective. And you need to listen to them because they're doing that work on the ground in workforce and clinical operation, clinical support. They're on the ground around data. And, you know, if this pandemic has revealed anything, we are crappy at collecting data as a society. That's why we don't know how many Black and brown people are dying of COVID-19, because we don't collect data across state, local, state, and federal government. So there's innovation opportunity, if I can call it that, in the data space. So there's so many places to go, whether it's processes, procedures, you know, how do we set up, as we're seeing right now with vaccinations. Just because really smart lawyers and doctors and scientists get in a room does not mean you will have the best solution. So we need some really innovative thinkers in the room to help us figure this stuff out.
Thank you so much. I'm going to ask a couple more questions about panelists, and then I'm going to jump over to the questions that are coming up on the Q&A. So thank you for sending them in, because we're going to start looking at them now. I'm just going to ask Dr. Tang to please add the behavioral lens to what Michael just added. You know, like there's so much of what we're seeing is that there is intelligence, there is science, there are so many there. We have this push forward and it is happening. And for those who are at community health centers, we knew it was happening. We knew about telemedicine before the pandemic, yet we were not able to practically have it done. Are you finding that as a behavioral health provider, do you see similar innovations that are delayed in the behavioral health space?
Absolutely. And I think just to provide an example from what Michael Kerry said, and I'm doing telehealth now as a psychiatrist, and clearly it improves care for some of my patients and it makes care worse for others, right? And we need a better understanding of which ones, who's this gonna be better for, and who is this worse for, and then what else can we do to better meet the needs of those patients? So give you an example. I mean, I've got some clients as a child psychiatrist, I've got some clients who, are working 2 jobs and live, 20 minutes away and are running out of their job, grabbing the other kid from school, grabbing the other kid from daycare, and then trying to make it to my appointment in person. That's really challenging. But if I can pick up the phone or Zoom into them and do a visit, that's better care for them, right? While she's still at work maybe, and someone, we can make that work better. But then if I have somebody who maybe has, multiple people in the home and doesn't have a private space, or is a parent who's going through their own traumas, maybe it's not so easy, right? And so what other technologies can we use? What other innovations can we use? So in the behavioral health field, there's a lot of focus now on kind of app-driven and person-supported type work, right? So could someone go on their phone and do some types of cognitive behavioral therapies, and when they reach a certain threshold of need, then connect to a human being on the other side, right? And maybe that's less stigmatizing for some people. So those are the kinds of technologies that we could think about. So I think there's just a lot of opportunities on telehealth, for example. To build on Michael Kerry's thought about data too, the behavioral health system needs a lot of investment in terms of technology. And one thing that we've been able to do at Dimock with honestly, like publicly available kind of, Google type software, right? Which gets you so far, it helps, but it gets you so far is, how can we draw data from our electronic health record about utilization, about what are our wait times right now, what are access to care, and bring that information to the frontline providers so they can adjust their care on really a day-to-day, week-to-week basis to better meet the needs of our population. That's been a huge innovation here at Dimock, using this publicly available technology. Absolutely, if we had good investment and the innovation of tech companies, I know we could take that to an even higher level. And then of course, what we really want to get to is that data gets to the patient level, right? Because it's great for systems to improve, and that's what we need. But when it gets to the patient level and the patients have at the tips of their fingers, the data, that's when we really know we'll have full accountability and full ability to maximize our resources. So that's another example.
Great, I love it. I really love it. I'm looking at the questions from the audience here, and Emily, I think a big theme that's coming up is this telehealth team, and I think Michael Kerry touched on it, and Mike touched on it too. So I'm going to ask you to answer maybe the first question, which is around, we know that telehealth is happening. The question is, the first part of the question was, are we leveraging the tool? Yes, we actually all did, and very quickly. For some of us, overnight, went from seeing people in person and actually having to social distance and start calls and then turn them into video very quickly. So if you could share from your perspectives, because you're with the communities, you're with the patients, what are they saying about it? What are the things that have gone well, and what are the things that are lacking, which is what the question was. What can telehealth do better?
Really believe it's a mixed bag. As Dr. Tang pointed out, it really depends on the person and their needs and their abilities. So for the patient that is using a government issued phone that only has a certain amount of minutes, telehealth is not ideal. It's not optional. They have 250 minutes a month. And if your behavioral health appointment is 45 minutes, you're left with very minimal in case of an emergency, contact for school. Where on the other side, if you, are gainfully employed and fairly financial stable, have a smartphone, then you are able to access the telehealth and meet with your provider via Zoom. There's also a language component too, just the language of technology. If you're not very tech savvy, being engaged in a telehealth appointment is going to be more difficult and more frustrating. A personal experience, the first time I used Doximity, I wanted to throw my phone, because I don't consider myself tech savvy, but my colleagues are like, oh, this is great. 2 seconds and we're good to go. I'm like, no, bring the person back to my office or let me go see them. So I really think it's a mixed bag. I think it allows us teaching opportunities with our patients for those that don't have necessarily those skills. But again, there are these socioeconomic barriers that our history has put into place for populations, unfortunately.
Couldn't agree more. I know I think we're all saying the same thing, which is it's helpful. There's more to do. It also should be a complement or part of the tool set that we have, but not the only tool set that we have. And I know, as Dr. Tang gave some examples, for those who are doing community outreach work, when you go to someone's home, there are things that you see that they may not share. Like, oh, wow, there are 3 steps here. So that must be hard for the person who's on a wheelchair, who's helping them up. And that you can't really see. So if there's a way to design a tool that allows us to see, yet be private, yet have maybe that'll be great. But for now, telehealth has a huge place in what we do. And it is an equity issue. We had telehealth available to those who could pay for it privately. And we didn't have it for those who were working hourly and therefore would lose a half a day of work to get to a clinic appointment. So we want to make sure it's still available. And we want to add other technology tools and complement the types of services that we provide. With that, there are 2 questions that I'm going to combine for you, Michael Kerry. There's someone who says, health inequities and wealth inequities are closely linked. Do you tie in economic justice into the mission of community health centers? And then the other person says, they loved your comment about if you're not at the table, then you're off the menu. And they wondered how ready are health systems to really adopt, rethinking this concept and really at this point, driving it into action. So would love to see, is economic justice a part of what we do, and are we ready to do more?
So economic justice, and great questions, both of those. Economic justice is built into what we do because it's how we started. And again, I mentioned earlier, it's about making sure people had clean water that then made them sick. You think about the Tuskegee syphilis experiment went through the early 1970s, where communities were taken advantage of because they didn't have the power, the agency, the influence to make sure that people who researched in their communities were ethical. Health centers came on board and were able to make sure that there was a voice for communities. And part of that was an economic justice message. As you heard Dr. Tang and Emily share, if you walk into one health center, you've seen one health center. But there's a common theme at a health center, that if you're in Brockton, Massachusetts, which is where I am, and in the health center that's just about a half a mile from me, you'll see a lot of Cape Verdean folks who work there because we live in a Cape Verdean community. You'll see a lot of Haitian Americans who work there because this is one of the largest Haitian communities in the country and in the area. The same is true for Lynn and Lawrence and Lowell and Mattapan and Dorchester. And one of the easiest and most fundamental ways that you change the circumstances of a community is you hire them, you empower them, you put money in their pockets and resources and help them with financial literacy. And health centers have been doing that since we were launched in 1965. The other piece of that is around, are we ready as a system? I don't know if we're ready for a lot of things, to be honest with you. I'm not sure if we're ready for this racial justice moment we're in. But what I do know is that if it takes the folks like those of you who are innovators or who are socially conscious, who want to make change as you do your own thing, to also focus on holding all of us accountable to deliver equity in how we do it. And that you make that a part of your engagement when you talk to hospitals and health centers and private practices and nursing homes and ambulance first responder organizations. You got to say, what are you doing around equity? I want to do business with you. But if I'm going to do business with you, I also want to know how you do business with diverse communities. There is so much you can do to influence how we do what we do. And I'm excited about that. I want to say, Dr. Pierre, before I go off of that question, I think me, Mike, and Emily are going to charge all of you for your innovation and all the money you make if we give you some good ideas. But I will say there's some. One that I'll leave with you is I'm not sure individuals pay much attention to their health outcomes over time. That we eat a certain way, we don't work out. And a lot of this stuff, Dr. Tang, is predictable. That if you come out of certain environments and you live a certain way, there's a certain outcome that can come from that. That's diabetes, that's heart disease. Those are incidents of cancer, Dr. Pierre. And how can you create something that allows people to sort of foreshadow and model, not just how they work out and what that'll mean in terms of body mass, but how their lifestyle produces an outcome that is likely, so that they're not waiting on a doctor once a year or every time they get into a annual physical to give them a sense for what they need to do differently. But how can they track that on a regular basis to say, hey, if I don't change how I eat, I might end up with diabetes by 30 or 40. And what is that tool? Now, we already have it when we work out, but I don't know if anybody who has it on a regular basis, you can pull up your phone and gauge your health status or your evolution. And I just give you that as an idea because I wish I had it. As a person who comes from a house with so many comorbidities, I wish I had something that would say, Mike, you really need to turn the dial on how you're eating or how you're living or how much you work out. So I give you that one. But if you do make money, I want all four of us to get a check.
I would love that check. So thank you so much. I think in the chat, there are more questions about that. So maybe that's what we'll do at the end. We'll wrap it up as our last question. I promise to bring that back for each one of us to give you a nugget of what we think you should explore as Michael is starting us to do that. We have like 8 or so questions in the chat and I'm trying to get them all in. So here's one of the things that I'm seeing as a theme here, which is how do you engage with community health centers? Like, you know, people are saying, well, I want to do a survey. I want to ask you questions. I want to ask your patients questions. I want to ask your caregivers and so on questions. How do we connect with you? So maybe I'll ask Dr. Tang, any creative ways for private sector entrepreneurs to partner with community health centers?
Yeah, absolutely. I mean, I think the easiest way is come knock on our door and ask, right? Come on over and say, hey, these are the kinds of things that I can offer. These are, what do you think? And, you know, ask individual health centers, not to give you more work, Michael Curry, but, you know, ask the Mass League, right? You know, think about, hey, what are the different kinds of needs do you guys have? What are the needs that you're hearing about patients and clients systematically? And what are the ways in which we could help you meet that? I think, you know, we are all looking for new partners and support. And to this idea of making money and writing us checks, I mean, there is money to be made here, right? In this accountable care era, so, you know, Massachusetts Medicaid as of March 2018 is on accountable care, which means that, you know, ideally it means if we're providing better health to our communities, then we're making more money, right? And what do we need to provide better health? We need better communication and better data is a huge piece of that. And in Michael Curry's example of putting data on his phone and other people's phones is part of that. And how do we improve that communication and data? That's where your support as people who know technology and people who know innovation are going to be incredibly helpful. You know, just to give an example, I was working for a startup called Health Leads in 2001, and we were working on social determinants of health. And so we know that, you know, if you walk down Blue Hill Avenue, there are food pantries, there are community agencies out there, but there's nowhere to put it all together. There is no phone book with that information in 2001, and now there's no Yelp that has all that information, right? So we were trying to build data, and of course, if you publish a book, that book is outdated the moment it's published, right? Because things are always changing. The grant runs out, And so, that program closes, or your Spanish speaking staff member leaves, and you can't serve that population as well. So in 2001, we were trying to build a database, and we were doing it, in the basement at 1 in the morning, basically. And that's not the way to do it. Now you have these wonderful entrepreneurial companies like Health Leads that has a Reach software, Healthify has a software on Bertha. There's many others that have made a critical community need, have met a critical community need, and they're partnering with electronic health records, health systems to build that. So I've seen in the last 20 years in this state the progress, and those companies I assume are all making money or on the road to make money. That's the kind of place that we need from you right now in 2021 to help take us to the next step in communication across behavioral health. We have all these privacy barriers, 42 CFR Part 2, HIPAA. These can be overcome, right? How can we get consent forms so that rather than signing some consent form, you could do it on your phone and give consent instantaneously, right? That should be possible, right? There should be PDF software where you can consent instantaneously to share your information with somebody else. Someone should build that, right? There's a lot that we can do, and we do need your help.
Great. I'm going to ask Emily to answer one of the questions there, and I see Michael's taking one of the questions, so I'll bring it back to him. One of the questions that came up was, if you've done work outside of the US, there are things that you can learn here. So someone said, in global settings, they do even text messaging as a way, it doesn't have to be a full-blown telehealth. It could be just text messaging as a way to get communities engaged, to do outreach work. So the question is, do you see any value in that type of level of SMS texting? And do you think that's an option that could be more accessible to people?
Absolutely. And some of our patients have actually requested that they receive text rather than phone calls. Again, part of that being, if they're using a government issued phone, they have unlimited text, but not the minutes. So I think that it's most definitely an option. It can be expanded upon, but then we have to look at the people that we are serving. I work with many patients that are, unable to read and write in their language of origin, let alone in English. And so the text message option will not work for them. And so it's really knowing your patient, knowing the population. And I believe it was Michael Kerry who said, you have to bring everybody to the table if you really want to know. So we can't go and, suggest that you design these great innovative things without knowing who you're designing them for and what their life truly is. Because if I can't read and write, I'm not necessarily just going to put that out on the table. You have to know me, and you have to make those connections. And you do that by opening up yourself and showing trust and showing, value in that person, no matter who they are, no matter what they look like, no matter what language they speak. And I think at community health centers, we're really able to do that.
Thank you so much, Emily. And thanks for highlighting that. I think there's a part that people assume or forget about, which is that healthcare is truly a private experience. And when you're trusting someone with what makes you uncomfortable, what's painful for you, and especially for us at community health centers where you're trusting us, not just with your medical problems, but sometimes your financial problems, your social problems, and so on and so forth. We have, as a team, developed all kinds of strategies and techniques to be attuned to what's going on without probing inappropriately so that it's comfortable for people to come in. So as tech partners, as innovators are coming in, that trust needs to be built. We can help you, we can facilitate that connection, but you have to spend the time, you have to invest the time, just as you do for customer acquisitions, to decide, and you do all of your marketing research and you take the time to do it. It's the same kind of principles with an added layer of equity and dignity, which is really important to us and therefore is the central driver of how we approach everything. And so with that, your comment about people who can't read really comes to mind, because I remember when I was doing groups with patients from different groups, I would do them in Spanish or in Haitian Creole, a patient said, I don't have my glasses, and they didn't have glasses. And so to me, that meant the exercise we're going to do, which was to draw something that made you happy, they needed support with. So I said, oh, no problem, you don't have your glasses, I'll draw it with you. And so those kind of things come in, and you would leave the group not knowing that this was someone who couldn't read or write. So those are the types of things that we know and understand, and that we would hope to share and through partnership could do. So I'm looking at the questions here, and it feels like they are a couple that we can answer quickly. So I think Stephen asked, what's the difference between community health centers and rural health centers? We're basically, if you think of community health centers, we are designed to serve the community, whatever it may be. And so in rural settings, we're the same. We have the same principles, the same funding, the same reporting criteria, but the way we deliver care may be different. So if it's a remote setting, we'll make sure that we have more support services that would go and cover the distance. We'll be more aware of the issues in that area compared to an urban setting where the issues that we partner with may be different. So we may be working with medical legal partners, we may be working with urban partners and so on. So we respond to the themes in addition to the medical needs. And we do vary at what the additional services we provide based on geography. And then there's another question that's around, and it seems to be the exact same question. So maybe that's how we're gonna wrap up today, because it seems like the two themes are, if we wanted to partner with federally qualified health centers, where do we start? How do we do it? And I think this is a question that's coming up because, you know, I've been a mentor in hackathons and in challenges and so on and so forth. And what I find is it's so exciting, it's so great, but it's often based on academic health centers, which is really great. I trained in an academic health center. It's transformed me in many ways. It doesn't always include community health centers. And so there isn't a natural place for innovators or tech, you know, they can go to most places and find the innovation lab of that health center or of that clinic or of that hospital. So how do they find federally qualified community health centers too? And the question I'm seeing is, where do we start? How do we contact you? How do we interview your caregivers? They're all the same thing, but they're basically about how do we work with you? So Michael Kerry, maybe I'll ask you to help us think through how we can do that.
Yeah, so there's so much to that question, Dr. Pierre, and I want to start with a paradigm maybe to approach that conversation. So you got to figure out what we do. And there's so much that we do that people don't understand. So if you think about just the building of a health center, right? The location of a health center, how do we expand? What's the infrastructure that we need in our buildings, the technology we need built into our buildings? All of that came up when Obama passed the American Recovery and Reinvestment Act and put billions of dollars in the health center, then the Affordable Care Act. But even in that first phase, which is just the actual structure we do care out of. And then when you get into when we're in a building and you're talking about workforce, how do we identify workforce, recruit workforce, diverse workforce, culturally competent workforce? How do we bring them in? How do we retain them? How do we allow them to develop and grow in their profession, like Dr. Pierre and Dr. Tang? And then the clinical side, what are the clinical supports? So I'm not giving you the answers to all of that, but it's the buckets, right? So Dr. Tang and Dr. Pierre could sit with you and give you a bucket list, a drop-down box of all the innovation they need to make their jobs easier and more efficient. And then you go into stuff like analysis, data collection, training and education, which we all do as health centers. There's so many areas we're in. And what we need is someone to, as the question said, how do we get in touch with you? Dr. Tang spoke to that, but I will caution you. Health centers aren't like some other entities. They're overwhelmed, even in this pandemic and before this pandemic. They're doing a lot with a little, and everyone and their mother got some new ask of a community health center. You know, I need you to vaccinate the nursing home. I need you to prop up the DCU center. I need you to respond to a flu vaccine years ago, or, and we stepped up, Dr. Pierre, for the earthquake in Haiti, where health centers were involved in supporting that, or Puerto Rico. What that means is they may not get back to you right away because they're already stretched. So don't be persistent. Reach out, reach the right people, right? Development, or reach a person like Dr. Tang or an ED, or reach the Mass League, but be persistent because you're tapping into people that are already overwhelmed with all the responsibilities they have. I just want to caution you on that, because I'm telling you, I've never seen, as we talk about that hallway with those doctors in hospitals standing in the superheroes are in the hallway, and the doctors and nurses are walking down the middle, and they're celebrating, they're applauding and bowing to their service. That's health centers too. Just in case you didn't know that. The people on this call right now are doing God's work, but they're doing a lot and with a little. So be persistent. And then with that paradigm, ask questions. What do you need? What are you looking for? What are your challenges? Ask those questions and you'll get some great ideas.
Great. I'm gonna ask maybe Dr. Tang to answer a couple of questions that I'm gonna pair together. someone said, can we talk a little bit about the caregivers of our patients? So the people, I'm assuming they mean here, this other layer. So we often think patient, provider, and then we forget that the patient has caregivers around them taking care of them. I'm assuming that's what that question is getting at. So can you talk a little bit, especially from your perspective, about what it's like to be a caregiver and to care for caregivers as a provider and what the needs are?
No, that's a wonderful, wonderful question. And we know that caregivers are so important, whether we're talking about parents, grandparents, other family members, other informal networks. And so it's really important to support them because when you support them, you're also providing better care for the identified patient as well. And again, this is where bringing technology to the patient and to the caregiver can help. Bringing the data, bringing the information can help improve care to exactly where it needs to be. I'm thinking about what Michael Curry said about people being stretched, and I hear that. I think as we think about startups, right? There's a lot of focus. As we think about the startup process, there's a lot of focus groups, right? And we think about expert people. And sometimes when people get seed funding, you think about, I'm going to get this big name expert and pay them a little money to help develop my product, right? The experts for the products that we're talking about are the people who are our patients, the people living in our communities, right? And quite frankly, they need the money way more, the $500 honorarium, way more than the Nobel Prize winner or the professor at Harvard. And quite frankly, are going to provide you better, more on the ground advice about how to make your product better, more marketable, and ultimately more profitable. So if you're fortunate enough in the startup process to come up with that seed funding or the initial rounds, I would think about that. And so when you're going to the community health centers or the Mass League, I mean, obviously, we've been working, long days for the past 10 months, past year. But if you're coming and you're saying, hey, we've got seed money to give to your patients, right? That will, that'll catch people's attention, right? To say that we're going to give $100. If you can identify 10 of our patients to spend an hour looking at this product and provide their feedback, that's going to attract a lot of attention and help us, find those 10 patients for you. And quite honestly, partner with you on that kind of development. So, hopefully that'll be another helpful piece of advice.
Great. And Emily, one of the questions they had is this piece about, what are resources that are good to learn more about health equity, to learn about community resources and so on. And so often when people say that, we think of like books and articles or people. I'd like to also think about movies or anything else, or even experiences. So Emily, is it okay if I ask you to share with the group how they can learn more about the best practices to support underserved populations, whatever that may be, a book, a story, whatever it is?
Come to the community. Come eat at one of our local small business restaurants. Come learn who we are. For me at Lynn, whenever we have a new provider, I take them on a walking tour around the downtown area. I point out our sister agencies. I point out our small tiendas. I point out, where our single room occupancies are. See who we are. I think that's really the best way to learn, is be there, be with us, walk with us. Don't read about us, don't watch a movie, but come. We're welcoming, we don't bite, come see who we really are and how we really live. I think that's the best way. And I can speak for Lynn, it's an awesome community, but we have this horrible theme song, Lynn, City of Sin, you never come out the way you went in. Like, what is that? No, I have the beach. I can go to a Vietnamese restaurant. I can go to a Guatemalan restaurant. I can go salsa dancing, come see all this great stuff that my city has to offer you, and then see who my people are. Don't read about who my people are. Be with us.
I love it. That is the best answer. It's the anthropological way of really doing community health. It is a big part of what we have to do. And it's a big part of what we had to do, literally. I think, I'm originally from Haiti, grew up there and then came to the US, and I've moved from one community to another. And I have to say, every time I've joined a new job or a new community health center, I've worked at 2 now, I had to learn the community each time. And for Harbor Health, which has Massachusetts to the, from Boston to the Cape, each community is very different. So I think that is the best advice you could have given Emily. It's completely true. And so I'm being mindful of time. We have about probably like 7 minutes together. I think it would be great for us to end with each panelist giving us, the 3 things that you would tell an entrepreneur to do. Before we do that, what I'll do is I'll look through the question and I'll answer a few very quickly that I think I can answer, if that's okay. So the first one is, someone said, can you tell me about the PACE program? PACE is PACE. It stands for Program for the All-Inclusive Care of the Elderly. The basic idea is that there are people who are 55 and above, and they have either different abilities or multiple medical problems that make them eligible for nursing homes. But if they live in a nursing home, they will, may not be socially engaged and lose connection with their communities and families, and they tend to decline faster. It also costs more to Medicare. And so what Medicare says is, hey, if you will support this person in their home or in assisted living and provide 11 disciplines that will go to their home, bring them to day centers, help them shower, help them feed, give them all their medical things and occupational therapy and everything, we will pay you the monthly cost instead of paying a monthly cost to the nursing home, with the hope that that person will live a longer, healthier life. So please learn more about PACE programs. We actually have 2 at Harbor. Many of the community health centers have partnered with them. The next question that I saw there was something that I'm going to ask you to think about as you're answering this question for the panelists, your last question, which is, someone commented that with COVID, more community health centers are offering COVID testing and COVID vaccine, not just to their patients and to the communities they serve, but to anyone. And so that comes with a lot, right? Because we always accepted everyone regardless of ability to pay. Our communities know us, our patients know us. And now that we're offering this, we're extending the public health system. We really are becoming a true public health system, delivery arm of it in the United States. Do we see ourselves beyond the pandemic continuing to do so? And if so, how? So if you could tie that as you're thinking about pandemic is over, telehealth is over, what are the major tech challenges? What are the innovation rooms? And what would it mean for us to be public health systems? So I think that's the last question I'm going to leave each one of you with. So who should we start with first? Okay, I'm going to call on one person. So let's go with Dr. Tang. I'm going to change the order this time. Give us your nuggets, pearls for our innovators.
Yeah, so I guess these would be my 3 pearls. One is be a connector. There's a lot out there. There's great agencies who've been doing this for literally centuries, like Dimock, that's 150 years old. We can use innovation and technology to help connect us closer together in a better way with our patients, with our communities. That is an incredible opportunity. The second is to start with the community served by community health centers, low income and minority communities. Some of my friends who are entrepreneurs say, well, I'll start here and then we'll get there. And I'll argue, start here, because communities served by health centers have different biopsychosocial needs. And starting here will make sure that the product is better. And again, there's money to be made here. And so that's also my third point, which is work with the patients and the clients, right? These are the people using the product, and these are the people who are going to make sure that you have the best product in the end.
Thank you. Emily, what are the 3 biggest problems that can help you solve?
Dr. Tang stole my answers.
I saw him copying. I really did see him. I saw him.
Yep, he copied off me. I think it really is just, again, knowing your patient population, knowing the patient population that you're working with, and making sure that you're not providing a bit of technology that's on a level that they are not. Make sure that the technology that you're developing is language appropriate, is education level appropriate. I think it's also valuable, for the patient or the individual using the technology to understand why what is the benefit of this? Okay, my doctor wants me to put in every day my blood sugar level on this app. So what? What is this doing? Where is it going? Make sure that they understand the value and how it truly can benefit their health and benefit others. Yeah, I just make it person-centered, bring it to the people.
Couldn't agree more. Michael?
I'll probably say something funny, which is if I had hit the Mega Millions or the Powerball, I would have invested in your ideas, but I didn't hit, so I'm sorry. I would say, you know, really it goes back to something Dr. Tang said earlier, and we've said throughout this call, my biggest passion is health equity. And we need innovators to help us figure out beyond policy, beyond practice, what is the technology, what is the innovation that'll get us past this hurdle that has Black and brown citizens and many immigrant communities dying at 5, 10, 15 years earlier than other Americans. We need to solve that crisis. It's quite frankly urgent. And not to be provocative on this call, I say if Black lives matter, it's not just about a knee on your neck, it's about the diabetes and the heart disease and the cancer. And we got to solve for that. And we need that innovation. I'm gonna leave the attendees of this call with some homework, right? Because there's an African proverb that says, if you know the beginning well, the end won't trouble you. If you know the beginning well, the end won't trouble you. The beginning for us, you need to do some research on, as Emily and Dr. Tang said, I want you to read Bonnie Lefkowitz's book, Community Health Centers, a Movement and the People Who Made It Happen. I want you to Google it right now after this call, Out in the Rural, a short documentary on the birth and movement of community health centers. I want you to schedule some time to go visit a community health center. I want you to visit Roxbury and just walk around and listen and ask people questions about healthcare and access and vaccines and testing. Once you do that ground study, it'll be like a comedian. My comedian friends tell me that they get their best jokes by walking around. So I think you'll get your best ideas by just being in our communities, engaging our residents, our patients, and I feel very inspired by the fact that you are looking to do work in this space and looking forward to seeing what you're going to do.
Thank you so much. I really, really, really cannot say how much of a pleasure it was to be on this panel with the three of you. Truly, your work has been inspiring and has made a huge difference for the communities that you serve. I'd like to thank MassChallenge Health Tech and really say thank you to the Massachusetts Public Health Commission for putting together this series. You know, at Babson, we talk about entrepreneurship and we talk about entrepreneurial leaders as a mindset. And to us, it's an idea that you start with what you have, you test often, and you actually take action. And in this case, what we're saying to you is that we want you to take action that includes others. And to do that, you have to listen to others, you have to walk with others. And we are also hearing from you that you would like a more structured way to do this partnership with us. And so we'll take that as a note about how we, as a League of Community Health Centers, as a movement of community health centers, can more structured way partner with innovators, so that just like you can Google a lab innovation lab at other health institutions, you can do the same thing for us, for community health centers. So I'm going to end that right here and say really thank you all for participating. The questions were great. For examples of equity, please follow the books and the resources, but really come and visit us, look at City Block, and please continue to participate in the future and upcoming sessions. The next one is called Achieving Equity in Telehealth Access, and it's going to be in February. So see you soon. Thanks for participating, and good luck to everyone.